Okay, so hello everyone, this is Daniel Shahid. I'm a fourth year medical student and I'm the co founder of USMLE Forum of Pakistan. Hope you all are doing well. Okay, so let's begin our question solving series. This is the episode 8, and so yeah, let's begin. Okay, so our first case, here you go. I think that by this time you might be familiar the question solving style of mine that I just read out the last line and then I skim the options and then I move back to the stem. So, yeah, that's it. So, autopsy is most likely to reveal which of the following cardiac findings. Mean the question is asking me about some sort of cardiac findings. Cool. So, arrhythmogenic right ventricular cardiomyopathy, bicuspid aortic valve, dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy. Okay. So, a 20-year-old student, university student, is found dead in the dead bed. Anyways, after complaining of exertional dyspnea and palpitation for several weeks. Not good. That's not good. Not good. He had no prior medical condition and did not consume alcohol, tobacco, or recreational drugs. His brother is healthy, but his mother had end-stage heart failure and received a heart transplant at the age of 40. Is this good? No, this is not good. Genetic analysis reveals a mutation in the TTN gene, which codes for titin, and autopsy is gonna reveal which of the following cardiac findings. Cool. Okay. So, first of all, if you look at this case, if you look at the buzzword of this case, so you're going to see that this is something familial. Something familial is going on in this patient, and not only that, but you can see that there's some sort of mutation as well. So, it is strongly suggests that the patient is having something familial, right? Something wrong in his genes. Okay, so now you might be thinking that which you have to think in such a way that which familial cardiac condition can lead to palpitations, and by palpitation you have to think about tachycardia, right? So now you have to think that which medical condition can lead to which familial medical condition can lead to tachycardia. Okay, so first of all, you all know by this time that TTN gene leads to sorry, that the mutation in TTN gene leads to which cardiac condition? Do you know that? You don't know? Ah, that's bad. You should know that the TTN gene mutation leads to familial dilated cardiomyopathy. Okay, familial DCM. So what actually happened that the titin protein, I don't know whether it's titin or whether it's titin. Different people pronounce it differently. I'm gonna call it titin or something. Sometimes titin. Anyways, so the titin protein plays a structural role in sarcomere elasticity and passive stiffness, and mutation in this gene impair normal myocardial function and leads to dilation and systolic dysfunction. So we all know that dilation of heart can lead to systolic dysfunction. First of all, remember for the rest of your life, I'm giving you a huge principle. That's the principle of CVS. That whenever heart is dilated, remember for the rest of your life, whenever your heart is dilated, your heart is prone to ventricular arrhythmia. Your heart is prone to ventricular tachycardia. Remember, it's a huge giveaway. Okay, so DCM, if we talk about DCM now, the DCM is often silent until it's not. It's mainly silent. It's not. If it's familiar, it might appear in later ages. So that's why many patients are undiagnosed until they develop heart failure, arrhythmias, or sudden cardiac death, especially during sleep or exertion. So you don't say that the sudden cardiac death in DCM will be in rest or due to exertion. It can be in rest or it can be due to exertion. So family history is a huge clue in this question that mother had severe heart failure and recurring transplantation, which suggests an autosomal dominant inheritance. You know that the mutation in TTN gene follows an autosomal dominant pattern. Okay, so on autopsy, you would expect to see an enlarged flabby heart with dilated chambers and impaired systolic function, and reduced ejection fraction. Of course, you won't see the reduced ejection fraction and systolic function on autopsy because the patient is no more alive. But that's the finding when we see the patient is alive. So that's it. So that's it about this question. So answer is of course TCM. So what is the huge giveaway? First of all, what you have to remember here, that the heart is dilated, whenever heart is dilated, it can lead to arrhythmias, and that arrhythmia is prone to sudden cardiac death. So whether you are having dilated heart due to any mutation, or due to alcohol, or due to any virus or protozoal infection like trypanosoma, so it's totally so it's a principle, yeah, it's a principle that whenever heart is dilated, it leads to arrhythmia, and that can lead to sudden cardiac death. What's a huge giveaway in this question? That mother had transplant and the patient is also having mutation. I don't know why people do this question wrong, but I have seen the statics of this question, and only 42% people have marked this question correctly. I don't know why people mark this question wrong when you are having a huge buzzword in this question. Okay. So why not the other options? First of all, the first option, it's linked with desmosomal protein mutation, and of course, it's not related. You know that the option A is a distractor here. You don't need to think about it. It's a vague option. Option B, bicuspid aortic valve. It's a structural valve issue, not typically leading to sudden death at this age unless associated with aortic dissection. And again, that it have a typical and a classic finding like chest pain radiating to back. So HCM. So HCM, it's linked to okay. First of all, which protein is linked to uh, uh, which protein mutation is linked to hypertrophic cardiomyopathy? Okay, do you guys know about it? Oh yes, you know about it. That's perfect. It's sarcomere protein mutation, like myosin binding protein Q, I guess, and yeah, it was a protein. That myosin binding protein C. Yeah, I'm right. Okay, so not titin, of course. So HCM can also cause sudden cardiac death, but the mutation here points to DCM. Restrictive cardiomyopathy, typically present with later in life, first of all, and associated with diastolic dysfunction, and not sudden death in a young healthy individual. So restrictive cardiomyopathy is also not the answer here. Okay, pretty cool, perfect, awesome. Now moving towards our second question. Okay, so a 5-year-old boy. Okay, so again, you are familiar with the pattern of mine of solving the question. Now it's totally up to you. How do you solve and how do you assess the question? It's totally up to you. Do what suits you. Anyways, so which of the following embryological process most likely led to this patient condition? So first of all, I know that it is asking about certain embryology now. Anomalous PVR, aortic arc constriction, deviation of infundibular septum, endocardial cushion defect, and linear development of aorticopulmonary septum. Perfect, perfect. Now you can pause the video and you can read this down. Okay, so a 5-year-old boy is brought to the clinic by his parents. Okay, a 5-year-old boy is supposed to be brought by his parent, not on his own. Anyways, due to the episode of cyanosis during mild physical activity since infancy, he has occasionally turned blue, cool, no, not cool, but blue. And these events are now happening more often. During such episode, he instinctively squats, and which help alleviate its symptoms. Family history recently moved to the family recently moved to the United States, and this is the boy's first medical examination. On physical exam, there is notable right ventricular impulse and a heart systolic murmur. So, which of the following embryological process most likely led to this patient condition? Now, the question is pretty easy, very easy. So you have to look at the buzzword first of all. Sorry. First of all, you can see that the key buzzword in this question are cyanosis on exertion. Okay, so I'm giving you first of all the stem summary. Cyanosis on exertion, history of turning blue since infancy, relief with squatting, and no prior medical checkups because he's an immigrant child. You know, in United States we have routine checkup. So but since he's an immigrant, so he's not having any routine checkups. Okay, so physical examination is prominent for right ventricular impulse plus systolic plus harsh systolic murmur. Now, so this was the summary. Okay, now think like me. Okay. So first of all, cyanosis in child, it suggests what? It suggests, yes, congenital heart disease. Perfect. Squatting. So I guess, can you tell me which classical condition, cyanosis in which condition classically improves on squatting? Yes, please. Do you know about it? I guess, yes, you guys know. Good. Territory of Fallot. Perfect. Harsh systolic murmur that points towards um, right ventricular outflow tract obstruction. And again, that happens in territory of Fallot. But again, that's a very non-specific finding. But if you are thinking about territory of Fallot, then it gives you a huge giveaway. Huge giveaway. Okay, only if you are thinking about TOF. But if you are not thinking about TOF, you are thinking about something else, or you are not sure that this question is about TOF or not. So harsh systolic murmur is not a huge giveaway in this question. It's just it's a non-specific finding. You can witness, you can hear harsh systolic murmur in many other different conditions. Anyways, so I just explained you that why the patient is having harsh systolic murmur, just because of right ventricular outflow tract obstruction in pathology of palate. Okay, right ventricular impulse. It suggests right ventricular hypertrophy, and on the ECG, it appears as right axis deviation. Okay, so if you are auscultating and upon auscultating you hear right ventricular impulse, that suggests again right ventricular hypertrophy. And if you are seeing, or if you are checking the ECG of such patients, so it will give you a right axis deviation. That's also a classic finding of right ventricular hypertrophy. Okay, so what should be the correct answer? A? No. Option B? Mm-hmm. Option D? No. Option E? Nope. Option C? No. Of course, option C is the right answer. I was just kidding. Let me explain you that. So first of all, the embryological basis of teratology of pellets is the deviation of infundibular septum, right? That's the embryological basis. I can't dip into the anatomy right of the I can't dip into the embryology of teratology of phallat at this moment. But yes, remember that deviation of infundibular septum leads to TOF. That's the basis of embryology. Okay, uh, of of TOF. That's pretty cool. Okay, so so what is teratology of phallat? So teratology of Fallot is characterized by four anatomical features. First of all, pulmonary stenosis. That's that means that first of all, pulmonary stenosis is the major determinant of the severity of the teratology of Fallot. Okay, so it's a very important thing to remember when you're talking about teratology of Fallot. The next thing is right ventricular hypertrophy. Why? Again, due to pulmonary stenosis, the right ventricular is facing a very high pressure, and it has to apply a lot of force to move the blood out of the right ventricle. Okay, overriding aorta, you can see here that the aorta is overriding over both right ventricles and left ventricle. Okay, so yeah, and a ventricular. Okay, in this figure, the overriding aorta is not shown in a very good manner, but keep in mind that aorta. If you are looking at this picture, then aorta is a bit on the left side, right? More towards the left side. If you are looking at this picture, okay. So, ventricular septal defect is another finding, an anatomical defect of the tetralogy of Pallet. Okay, so but I think that I should explain a bit about the embryological defects. So, TOF is actually caused by anterior and superior deviation of infundibular, which is also called as, I guess, conal septum, okay, which misaligns the aorticopulmonary septum, and this leads to VSD and right ventricular outflow tract obstruction and pulmonary stenosis. Okay, so but what you should remember here for the rest of your life, that it is due to the deviation of infundibular septum. That's it. Nothing more, nothing less than that. Okay. So, yeah, another important thing I need to highlight here, that you might think that why squatting helps in the teratology of pellets. So squatting increases the systemic vascular resistance, and the increase in systemic vascular resistance cause the reduce in right to left ventricular shunting across VSD. Okay, why again? Because if the systemic vascular resistance will increase, then then the pressure in the aorta will increase, and the afterload to the left ventricle will also increase. If the afterload to the left ventricle increases, so it creates a high pressure in the left ventricle, right? So if the pressure in the left ventricle is high, so of course, if you have learned the physics in your school, in your college, so you know that if the pressure in one chamber is high, then it can't lead to the diffusion or the transfer of molecules in that chamber, right? So you remember that molecules always move from higher pressure to the lower pressure, but if the pressure in the ventricle is too high, of course the gradient is now reversed, and you can't pull the deoxygenated blood, means the blood from the right ventricle into the left ventricle, right? You should know about this. Okay, so that's reduces ultimately what's the point here, that whenever the pressure in the left ventricle is increased, and why it is increased, because the increase in afterload. Why increase in afterload? Because the increase in systemic vascular resistance. Okay, so that leads to reduced right to left shunting, and that improves the oxygenation and less cyanosis, because if the right to left shunting is decreased, then it means that deoxygenated blood won't mix into the oxygenated blood, and that would lead to a pure oxygenated blood to flow from the left heart, and that improves the cyanosis. Okay, that's perfect. So why other options are wrong here? So first of all, if you're talking about option A, anomalous pulmonary venous return. So this is a part of total anomalous pulmonary venous return, TAPVR. It's a congenital heart disease, but it doesn't present with squatting or a harsh systolic murmur. It doesn't improve with squatting. If you're talking about option A, and there is no harsh systolic murmur here. Okay, so the murmur is often absent or soft. Instead, you get a pulmonary overcirculation and the right heart, a heart dilation. So that's a totally different finding. In the anomalous pulmonary venous return, you see a dilated right heart, not a thickened right heart. Okay, so that's a totally different finding again, and the option was too vague here. Okay. Aortic arc constriction. So that refers to the coarctation of aorta, and of course, coarctation of aorta is not a cyanotic congenital condition. Is a non it's a non-cyanotic congenital heart condition, and it presents with differential blood pressures. Like upper extremity blood pressure will be high, lower extremity blood pressure will be low, and there is no link with squatting or cyanosis, and it's usually identified by weak femoral pulses. Remember, the buzzword of aortic arch constriction means aortic coarctation of aorta. What's the buzzword for it? The low femoral pulses, right? Okay, perfect. Option which should be the next option? Option C, yeah. Yeah, sorry, option D. Okay. So, endocardial cushion defect, my friend, that's seen in, yes, that's seen in, you should answer. It's seen in three, two, one, boom. It's seen in atrioventricular septal defect, AVSD. often in children, in Down syndrome children. Okay. Okay. So it causes left to right shunting, not cyanosis, because you should know that if the blood is shunting from left to right heart, it won't lead to cyanosis. So as the case in shunting, sorry, as the case in squatting, when in teratology of Fallot. So when you're squatting in teratology of Fallot, the blood shunts from left to right, not right to left. And in the resting condition, the blood is shunting from right to left, and that leads to cyanosis. Anyways, so it causes, if you're talking about ABSD, so ABSD causes left to right shunting, that won't lead to cyanosis. And cyanosis, if the cyanosis occurs, so it's a very late finding, and it's called as Eisenmenger syndrome, right? So the cyanosis in ABSD, it's a very late finding, and it occurs due to pulmonary hypertension, when the pulmonary heart hypertension develops. So again, that's a different condition. So also it also lacks a squatting behavior. So again, that's why they have given the information of the improvement of condition with squatting. So that's a huge giveaway in this question. Okay, so perfect. Now, the option C, linear development of aorticopulmonary septum. Okay, this phrase, I guess, refer more generally to the formation of outflow tracts, but does not account for deviation of that causes TOF. So, and it's not the specific embryological error here. So I guess option E is also a vague option, and that simply mark any specific embryological step in the development of heart, and that step doesn't refer to TOF. Okay, for the TOF, you have to remember the important thing that it's related to infundibular septum defects. What the huge giveaway for the rest of your life, whenever you're talking about TOF, think about infundibular septum. Even if you don't know what is infundibular septum, you should know that it's related to this when you are appearing in your step 1 exam. And if you're talking about ASD and VSD or AVSD, then think about endocardial cushion defects. Nothing more, nothing less than that. Even if you don't remember the embryology, that two things will make sure that you're gonna mark the correct answer in your actual exam. Okay, so awesome, perfect. Now, the next question. Okay, so you can read the question. I am starting. Okay, so enlargement of which of the following cardiac structure is most likely cause of her symptoms? Okay, so the question is asking about the enlargement of any of the following structure. Okay, now I have to read the symptoms of the patient now. Okay, a 35-year-old woman presents with difficulty swallowing solid foods that has gradually worsened over several months. Okay, it means that progressive dysphagia. Okay, let me tell you one thing, and let me give you a principle that you have to remember for the rest of your life. There are two types of dysphasias. One is progressive dysphagia, and the other is non progressive. In the progressive dysphagia, you have to think about that any there is a compression of the esophagus from the outside, right? You have to think like that. The other one, non-progressive, you have to think, okay, that okay, it might be possible that there is certain pathology in the heart, in the esophagus, like achalasia, right? Because in achalasia, the dysphagia is not progressive, right? Let me tell you what does progressive dysphagia means. The progressive dysphagia means that initially you are having difficulty in having solid foods and swallowing the solid foods. Later on, you are having the difficulties in swallowing liquid foods as well. So that's a classic finding of progressive dysphagia, and you have to think about that something is compressing the esophagus externally. In the non-progressive dysphagia, like you are having, you cannot swallow liquids, you cannot swallow solids from the day one. So I have to think about some pathology lying inside the esophagus, like achalasia, as I've mentioned. Anyway, so this patient is having some progressive dysphagia. She describes sensation of food getting stuck behind her chest bone. That's a huge giveaway what's actually happening, but denies any pain or acid reflux. So the patient is actually denying that The stem is actually defining you and explaining you that whatever the condition is, it's just due to some external compression. Nothing is that is abnormal in the esophagus. In addition, she reports experiencing heart palpitation, shortness of breath. During physical activity, she immigrated from India and was previously treated for rheumatic heart disease. A barium swallow study reveals an external compression of the mid esophagus, enlargement of which of the following condition structures is most likely responsible for her symptoms. Okay, so what do you think the answer should be? What you are thinking? Okay, let me mark first of all the important things here. Okay, that's cool. Now, I give you few minutes, I give you few seconds or whatever. I give you nothing. And I'm going towards explanation. First of all, the core clinical clues here. Now I'm just giving you a summary of the stem. So the core clinical symptoms, core clinical clues here are progressive solid food dysphagia. Again, that's more likely a mechanical obstruction. No reflux or odynophagia means no pain while swallowing the food. So that's not like esophagitis. Okay. Okay. So we have ruled out the esophagitis. Again, we have ruled out any pathology lying inside the esophagus. Okay. Barium swallow shows mid esophageal compression. Okay. Okay. So that suggests again an external mass defect effect. Okay. History of rheumatic heart disease, likely mitral valve disease. Okay. And mitral rheumatoid heart disease affect mitral valve, then aortic valve, then tricuspid valve. It's the preference that I've just talked about. So the preference is for mitral valve. Okay. So and what does the rheumatic heart disease does to the mitral valve? Yeah, mitral stenosis. Remember this. Okay. Palpitations and dyspnea on exertion. Palpitation again suggests certain tachycardia or might be fibrillation or something like that, right? Okay, we will look into this. Okay, perfect, awesome. Okay, so first of all, the patient was immigrant. Yeah, she's an immigrant. Uh, in United States, whenever you are having rheumatic heart disease or rheumatic fever, we give the patient antibiotics for a long time. So if the patient is an immigrant, there is a huge chance that she have missed her or she was not guided properly about the antibiotic regimens, about the antibiotic course, of course. Okay, so a rheumatic heart disease. First of all, now I'm connecting this from one point to another point, and then I'll lead to the answer. First of all, the patient is having rheumatic heart was having rheumatic heart disease. Rheumatic heart disease leads to pathology in mitral valve. Which pathology? Mitral valve stenosis. Mitral valve stenosis can lead to left atrial dilation. We all know about it, that mitral valve stenosis leads to left atrial dilation. And I've told you that whenever there is dilated left atrium or right atrium or any atrium, we got two, so it leads to atrial fibrillation. Perfect, right? And that's why the patient was having some palpitations, okay, and shortness of breath. Perfect. Now, you know that left atrium is anatomically arranged in such a way that if it's dilate, it leads to compression of mid esophagus, right? Perfect. So the anatomical fact here that esophagus lies posterior to the left atrium. So when left atrium enlarges, it compresses the esophagus and usually at mid thoracic level. Let me show you something. You see that here is the left atrium is dilated. And this dilated left atrium is compressing the esophagus, right? You can see the vertebra here, and just anterior to the vertebra, you got esophagus. Okay, so the enlarged left atrium is now compressing the you know esophagus, right? And that leads to esophageal compression and hence dysphagia. Awesome. So that's the answer is option A, of course. But other options are wrong. I don't think so. That if you know about this anatomical relation, you need to skim over the other options. So reading other options and solving and talking about other options is totally wasted of time of yours. So